Wish you all a very good afternoon and a very warm welcome. On behalf of Chess Research and Training Private Limited, it's my privilege to welcome you all to the 68th practical updates for respiratory PGs via the web. This is a special purview as we celebrate, or rather, as we observe the World Asthma Day on the first Tuesday of every May every year, and the entire month is observed as the World Asthma Month. It is indeed a pleasure to bring you all the latest changes that have happened in the international guidelines, that is the Global Initiative for Asthma. And it's a privilege to bring it to you through this particular purview. This year, the theme of World Asthma Day is also a very pertinent and very important theme, which says access to anti-inflammatory inhalers for everyone with asthma, still an urgent need. So there still is a lot that we as pulmonologists need to do, and how we can do it better is what the GINA 2026 has laid some directives upon, which we will be sharing with all of you today. It's my privilege to welcome and invite all the students who have joined us over here today. I believe there are more than 2,000 students who have joined us online to attend this purview. I would like to welcome and thank all the heads of the departments of the pulmonary medicine departments and the medicine departments in all the colleges for encouraging their students to attend this purview and be updated with the latest knowledge in asthma diagnosis and management. I'm very happy to introduce all of you to our eminent faculty panel over here today. We have amongst us Dr. Sandeep Salvi. I'm sure all of you are well aware that Dr. Sandeep Salvi is a member of the scientific committee of the Global Initiative for Asthma. And through him, we have had a little bit of contribution that we could make to the GINA guidelines for the past few years. Dr. Salvi is the chairman and director of CREST, that is Chest Research and Training Private Limited, as well as Pure Foundation. He is the past president of the Indian Chest Society. He is also the member of board of directors of the Gold Committee. And we're very happy to share that he has consistently ranked amongst the top 0.01% of respiratory scientists for the past 5 years, as per the Stanford University ranking list of research scientists. And he ranks number 1. And currently his global rank is 35th amongst more than 67,000 scientists. In 2024, Dr. Salvi was conferred with the World Lung Health Award by the American Thoracic Society. And Dr. Salvi is going to give us an insights into what is new in GINA 2026 through this presentation today.
Thank you.
It's a pleasure, sir. As pulmonologist, I'm sure you all will have to see a lot of children as well, because even for a child suffering from asthma, the parents would like to see expert guidance from a pulmonologist. And hence, we are very happy, and it's a privilege to introduce Dr. Bornali Bhattacharya to all of you. Dr. Bhattacharya is a consultant pediatrician in Pune, and she's the course director for CASPER as well as CASPER Clinics program, which is a training module that CREST runs for pediatricians, practicing pediatricians. Dr. Bhattacharya has more than 25 years of experience in the field of asthma. She's a master trainer of the asthma training module of the Indian Academy of Pediatricians. She's been a master trainer for the under 5 V's module of the IAP, and also the faculty of the advanced asthma course of the National Respiratory Chapter of Indian Academy of Pediatricians. She's specifically dedicated to improving awareness about asthma and its diagnosis, management amongst children, and in educating parents about how to handle their child's asthma. Dr. Bhattacharya, ma'am, really looking forward to your session today. We have amongst us Dr. Rajadhar. I'm sure all of you are aware how wonderful and how expert a pulmonologist, academician, researcher Dr. Raja Dhar is. Dr. Dhar is the director and head of the Department of Pulmonology at the CMRI hospitals, and he's also the director of education and research at the National Asthma Allergy Bronchitis Institute in Kolkata and West Bengal. And it is always a pleasure to listen to the clarity with which Dr. Rajadhar shares his insight on the topics. So we are looking forward to your session today as well, sir.
I would just like to add, Dr. Monica,
Yes,
Dr.
sir.
Rajadhar has been the secretary of the Indian Chess Society for a while now, and he has gained international recognition in bronchiectasis. So
Yes.
he's part of the lead part of the bronchiectasis program by the European Respiratory Society. So
Yes.
he's recognized as a global figure in this field. It's very nice to have him here.
Absolutely right. Thank you, sir. Thank you for that, for adding that. We have amongst us Dr. Vijay Kumar Chetty as well. Dr. Chetty is the senior pulmonologist and therapeutic bronchoscopist at the Department of Pulmonary Medicine at the Apollo Health City. And he's also the professor and head of the Department of Pulmonary Medicine at the Apollo Institute of Medical Science and Research in Hyderabad and Telangana. Dr. Vijay Kumar is also an ardent teacher, and he has been a part of a lot of our training activities as well as faculty for national and international conferences. Dr. Chetty, a pleasure to have you here, and looking forward to your session as well. That's me. I'm Dr. Monica Barney. I'm the director and head of the training department at Chest Research and Training Private Limited. And I have my wonderful team with me, Ms. Madhura Gauri Shevde, who is the manager of the training programs at CREST, and Ms. Aishwarya Nair as well. To quickly run through the agenda, we will be discussing what is new in GINA 2026. Dr. Sandeep Salvi will be sharing his insights on what the changes are, and believe you me, GINA has a lot of new additions this time. Post that, we will dive deeper into the evolving concept of MART strategy in children, which is more extended now amongst the pediatric age group, and Dr. Bhattacharya will be sharing her insights on that. And then we will have Dr. Rajadhar speak about the anti-inflammatory reliever, the whole concept of AIR and why it is so important for all of us to know about it. Dr. Vijay Kumar Chetty will speak to us about the innovation in inhaler devices to match the right patient profiles. And then we will have a panel discussion where Dr. Salvi will discuss what are the novel approaches that can impact patient outcomes in the real world. I would like to request all of you to please share your queries, questions. You have a provision to send your questions. So please use that link and send all your queries so that we can discuss them at the end of the session. And with that, and of course, in the end, we will have the quiz and announcement of the prize winners of the previous purview quiz. So with that, now I would like to invite Dr. Salvi, sir, to discuss about what is new in GINA 2026. Thank you all very
Okay. Thank you. Thank you, Dr. Monica, for those kind words of welcome and introduction. Indeed, an honor and a privilege to be a part of this purview. Time just flies. 68th purview over the last so many years. And if you make a rough calculation, we would have trained at least 25,000 postgraduate students over the years. Today is a very special day because we are going to be celebrating or recognizing the World Asthma Day, which was held on the 5th of May. So we call it the World Asthma Week, which is held on the first Tuesday of every May. The Global Initiative for Asthma was started in 1993 by the National Heart, Lung and Blood Institute from the US, along with the US National Institute of Health, in partnership with the World Health Organization. And since then, GINA has been sharing all the latest knowledge in the form of a strategy report that they publish now every year. We heard about the theme for the year, And I think that is probably the most important message for each postgraduate student who is listening to this. None of your asthma patients, be it mild intermittent, mild persistent, moderate, or severe, should be denied an inhaled corticosteroid. Period. I think that is the most important treatment for asthma. Keep that at the back of your head, and no patient should be treated without an inhaled corticosteroid. The 2026 GINA document was released on the 5th of May, that is just about 2 days ago. And I would like to uh, acknowledge the work of the GINA committee. On the left hand side, you see the board of directors of the Global Initiative for Asthma. And on the right hand side, you see the GINA Science Committee, which is chaired by Dr. Helen Reddell from University of Sydney in Australia. I have been very fortunate to be a member of this science committee for the last 6, 7 years now, and I've seen it firsthand the amount of effort and hard work, amount of debate and discussion that happens on newly published data, which we then filter off and decide whether it needs to be included in the GINA document. 18 months of hard work for this year's GINA 2026 report. And I can tell you that there are lots of additions, lots of new information that has been included in the GINA 2026 report. Let me start quickly. I mean, I have only 20 minutes, so I'm going to just share with you some of the key findings of the report. Now, remember that diagnosis of asthma is essentially clinical. And therefore, you have to be very, very well versed with the clinical presentation of asthma. The GINA document spends a lot of effort in highlighting this. So, when should you suspect asthma in your patients? When they have symptoms that vary over time and vary with intensity. And what are these symptoms? Cough, shortness of breath, and wheeze. These symptoms are often worse at night or when they wake up the first thing in the morning. They're triggered off by exercise, laughter, allergens, or cold air. They occur or worsen with viral upper respiratory tract infections, and a classical exercise induced asthma presents with shortness of breath that gets worse after stopping the exercise, not while performing the exercise. And that's the hallmark of exercise induced asthma. So do keep this at the back of your head if you're suspecting asthma in your patients. And these are the symptoms that do not normally fit into the diagnosis of asthma. If a patient has chronic sputum production, think of other diagnoses. Shortness of breath associated with dizziness, lightheadedness, or peripheral tingling. And I'm sure you know what this diagnosis is, right? Chest pain, exercise induced dyspnea with noisy inspiration. Noisy inspiration. So you know what it is. And then a localized wheeze rather than a generalized polyphonic wheeze bilaterally. So I think keep a watch of for these symptoms in your patients that you would see on a regular basis. Now, spirometry, unlike for COPD, where it is absolutely necessary to have spirometry to make a diagnosis of COPD. A post-bronchodilator FEV1 upon FVC ratio less than 0.70 is a necessity to make a diagnosis of COPD. For asthma, spirometry is not a necessity. And the reason is a lot of these asthmatics will present with normal spirometry report. So do keep this at the back of your head. For a long time, there has been a debate about what should be the cutoff value for FEV1 upon FVC for asthma. For COPD, it is 0.70. For asthma, there is a thought that we should extend that 0.70 to 0.75. So if you are suspecting asthma in an adult, then you may increase the threshold of the ratio to 0.75. However, if you're seeing children less than 18 years of age, then the threshold for the ratio needs to be increased to at least 0.85. So you will make a diagnosis of asthma in a child suspected of the disease if the ratio is less than 0.85. There are some references that also say that you can increase it up to zero point 0.9. So these are the thresholds for the ratio. Then comes the bronchodilator responsiveness. There's a lot of emphasis on this in the 2026 report because presence of a bronchodilator responsiveness is believed to be a very strong supportive evidence for asthma. And the cutoff values for the threshold are FEV1 more than or equal to 12% and more than or equal to 200 ml in an adult. And in children, it's only more than or equal to 12%. You don't need the 200 ml criteria. If you want to look at bronchodilator responsiveness with a peak flow meter, then the cutoff is more than 20% in an adult and more than 15% in children. Excuse me. Apart from this, there are other biomarkers that are very specifically mentioned. The GINA 2026 talks about FeNO as an important biomarker in asthmatic subjects. So for adults, the cutoff value is more than 50 parts per million, and for children, it is it is more than 35. Remember that a low FeNO does not rule out asthma. I think it's important to understand this. Blood eosinophils have also been mentioned as an important biomarker for asthma, but they do not mention a threshold. They say that every country should have its own threshold depending on what the average blood eosinophil counts are. So, this is what the GINA 2026 report specifically highlights. Now, what is interesting is the bronchodilator responsiveness criteria, that is FEV1 more than or equal to 12% and more than or equal to 200 ml, was first introduced by the ATS-ERS in 2005. However, in 2022, the ATS-ERS working committee came up with a new criteria for bronchodilator responsiveness. They suggested that a change in FEV1 more than 10% of the predicted FEV1 is what should be considered as positive bronchodilator responsiveness. Now, the GINA has been avoiding this revised or the new ATS-ERS criteria. They have been fixing their the criteria only on 12% and 200 ml. This year, they have given us a justification for why they have stuck to that. So this is a paper that was published in the ERJ Open Research last year, a very large study of 30, close to 35,000 people. And they compared the 2005 criteria versus the 2022 criteria. And you can see that there are four options: 2005 plus, 2022 plus. Both of them show good bronchodilator responsiveness and so on. Now, what they were able to show is in that discordant population, where they met the 2005 criteria but did not meet the 2022 criteria, they had a higher burden of symptoms such as wheeze, shortness of breath, and chest tightness. And therefore, they concluded that the new criteria does not seem to be appropriate. And therefore, in the 2026 document, GINA has stuck to its old criteria for bronchodilator responsiveness of 12% and 200 ml, and they do not recommend the use of more than 10% of predicted for FEV1 as the revised criteria. They don't recommend it. This is a wheel that GINA has been proposing for many, many years, and I thought it is important because it tells us something so very important of asthma management. It is not only about pharmacotherapy or prescribing the inhalers, the correct inhalers. It's about assessing, confirming the diagnosis of, if necessary, look at these symptom control and modifiable risk factors, look at comorbidities, look at inhaler techniques and adherence, and then look at patient preferences and goals, which are also very important. Are the caregivers or are the parents happy with the treatment? Because if they're not going to allow their children or their relatives to adhere to the treatment. Then comes adjust. So the treatment of modifiable risk factors and comorbidities. non-pharmacological strategies, asthma medications, including ICS, and so on, including education and skills and training. And then finally, review symptoms, exacerbations, side effects, comorbidities, lung function, and then consider biomarkers. I think this wheel is extremely important when it comes to asthma management. Each of those components, each of these three components are extremely important. So please follow these in whenever you see your patients of asthma. There are three terms that I would like you to that I would like to introduce you to you before I go to the next slides. These are concepts which are not very novel. They've been there in the GINA documents for a few years, but not many people seem to understand it, and therefore I'm going to repeat it over here. AIR is not All India Radio. It is anti-inflammatory reliever. So it is a reliever medication that also contains an anti-inflammatory component. The anti-inflammatory component will always be a steroid, and the reliever will always be a quick onset of bronchodilator, be it short acting or be it long acting. Then there is this concept called air only, where this is the only treatment that we recommend in that stage of asthma, anti-inflammatory reliever only. And then the third element is MART, maintenance and reliever therapy. Maintenance and reliever therapy means that this is the medication that you should use for maintenance, and this is the same therapy that you should also use for reliever therapy. And I'll come to this in the subsequent slides. So here is the new staging management of asthma, which I think is very important. There are quite a few changes over here. So for adults, adolescents, more than 12 years, the track one is the preferred management strategy. If the severity of asthma lies in step one and step two, then the only treatment that you should give is all anti-inflammatory reliever, not all India radio. So it is air only. That is the only treatment that you need to give as needed. But the reliever also is exactly the same medication. So we would still call it air. Okay. So step one and step two is anti-inflammatory reliever. This has replaced short-acting beta agonist completely. Then step three, we use MART, that is maintenance and reliever therapy. And this is with a low dose maintenance corticosteroid with a long acting bronchodilator, which also has quick onset of action, that is formoterol. And the reliever medication is the same. So low dose ICS containing formoterol. Step four is MART with medium dose of maintenance ICS plus formoterol. Reliever medication remains the same. And in step five, same MART with high dose of maintenance ICS containing formoterol. Here, they also suggest that you should consider adding a long-acting muscarinic antagonist, therefore a triple drug combination. You should also consider biologicals such as anti-IgE, anti-IL-5 or anti-IL-5 receptor, anti-IL-4 receptor antagonist, and then anti-TSLIP. So these are the step five management recommendations. The track two, which is the second choice that the GINA 2026 recommends. So here, it's only the step one where air only is recommended. And here, instead of formoterol, you can use a SABA. So ICS plus SABA is the anti-inflammatory reliever only in track two, step one. The reliever is also the same. And if you need to have two inhalers for that, you use two inhalers. Or if you do not have an ICS plus SABA combination in your country, then only you think of using short-acting beta agonists like salbutamol. Now, in India, we have ICS plus SABA in the form of beclomethasone and salbutamol, which is the first inhaled medication that was available in India for ICS plus SABA. Step two is low dose maintenance ICS, and the reliever as I've written below. Step three is it should be medium dose. Sorry, I forgot to put that. Medium dose maintenance ICS. Step four is step three and step four is the same. Step two and step three are same with low dose. Step four is with medium dose, and step five is with high dose. The rest of the treatment remains the same. Now, this has changed because of a very big publication called as the Batura study, published in the New England Journal of Medicine last year. So, based on this, SABA as a reliever has now been removed. And I think that's a massive change that has happened in GINA 2026. There is absolutely, as you can see here in track one, there is no use of SABA that is recommended. It is only recommended in track two, that too if you do not have access to ICS plus SABA. Now, how much of the reliever medication are you allowed? So here is the upper limit. Children between 6 to 11 years, it's not, if you need more than 8 inhalations per day, then you need to go and visit a specialist. For adolescents between 12 to 17, you're allowed up to 12 inhalations before you do that visit. And for adults, it is more than 12 inhalations. So the numbers have now come down for the upper limit of these medications. For the severe asthma, I showed you in step five, uh, add LAMA. So this is the triple drug combination. There is a new mention of biosimilar anti-IgE, which is omalizumab IgEC, which has now come into the GINA 2026 as a new addition. And the indications are for children above the age of 6 years. Then there is a new mention of depemokimab, which is a long-acting anti-IL-5 monoclonal antibody. You need to give the subcutaneous injection once in every 6 months. So this is a long-acting anti-IL-5 monoclonal antibody, which seems to have shown some beneficial effect in patients with asthma. That's a new addition. And then there is a whole table about which of the biological therapies that you should use in a patient. And I'm not going to show you that because you can go to the GINA the report and you'll find that table in that. Then there's a big discussion about why not treat with inhaled short-acting beta agonists alone. And the science that has been emerging over the years has been so strong that only SABA use in asthma management has been shown to be associated with a large number of adverse events. And I'll show that to you in the subsequent slides. But I think this is one of the major changes that has happened in GINA 2026. Here is a case report that was published quite a few years ago. Salbutamol induced severe lactic acidosis in acute asthma. And this is a 42-year-old gentleman who had asthma, who had shortness of breath and a runny nose. He started using the salbutamol inhaler, did not get relief. Shortness of breath got worse. So he used more salbutamol through the inhaler, brought to the hospital where he was given nebulized salbutamol, 35 milligrams over a period of a few hours. And you can see in this report on the right hand side, this gentleman ended up going into lactic acidosis. Now, this has been known, but the reports have been very far and few. But nowadays, there's a lot of reporting about salbutamol-induced lactic acidosis. The problem is when patients who have lactic acidosis, they still feel short of breath. And therefore you feel, oh, he's still not getting relief from the breathlessness. Increase the dose of salbutamol, either through the nebulizer or through the PMDI with spacer. That actually makes the lactic acidosis worse, and that worsens the shortness of breath. So please keep this at the back of your head, because now this has got a lot of mention in GINA 2026. Here is a case study that was published from the Ramaya Medical College, Bengaluru, in Curious last year. A very similar case, but this was a lady who took 20 tablets of salbutamol of 2 milligrams because her shortness of breath was not getting relieved. So she kept on dosing herself with salbutamol with the hope that her shortness of breath will get relieved. And you can see here that she had hypokalemia, tachycardia, and lactic acidosis. The ECG showed a very classical QT-C prolongation. So salbutamol toxicity is something that is not new, but we should be aware about it. And because of all these adverse events, the use of salbutamol is reduced. There has been an inadvertent misuse of salbutamol inhalation therapy in patients with asthma, which is actually worsening the problem of asthma rather than giving them benefit. Acute exacerbations presenting with mild exacerbation, moderate exacerbation, or severe exacerbation. I don't want to go through the details of this, but it gives a very nice table and a flow of how do you manage these patients. Review response at 1 hour or earlier. So please do go through this table in the new GINA document. I just wanted to talk about something interesting that they have added. If your asthma patient has come to you along with features of anaphylaxis, then the first thing that you should do is give them epinephrine first. Uh, uh, Intramuscular injection of epinephrine is what we usually use, but there is in this GINA 2026 document a recommendation for use of nasal spray epinephrine as well. Now, nasal spray epinephrine is becoming available in many countries. I am hoping that this will also be made available in India, and therefore we should be all be aware about nasal spray epinephrine. But make sure that you do not use nasal spray epinephrine in small children. In them, you should only use intramuscular injections of epinephrine. Then there's a very interesting section on inhaler technique. We all talk about how doctors do not know how to use inhaler devices correctly, how patients do not know how to use inhaler devices correctly. So there's nothing new in this, but there's a lot of emphasis that if your inhaler device technique is incorrect, then that is a major contributor to poor asthma control. And there are very two important messages over here. If you're using a dry powder inhaler, the breath that you take in has to be strong, deep, strong and deep breath inside, fast and deep. Whereas with a pressurized meter dose inhaler, it has to be a slow and deep inhalation. And I think a lot of patients, a lot of doctors don't understand the importance of this because this is really, really important. Then the use of PMDI with a spacer in an acute exacerbation. In children, we knew that we can recommend them to use tidal breaths, and you make them do tidal breaths about 5 or 6 times, and that is good enough rather than taking a deep inhalation and holding your breath. Because during an acute exacerbation, you cannot do that. Now they have expanded this to adults as well. So whenever an adult patient comes to the emergency with acute exacerbation, you can give them a PMDA with a spacer. No need for a slow and deep inhalation and breath hold. You can do tidal breaths in the adults as well. And then there is this mention about shaking of the PMDI immediately before each activation. And this is so important. I can tell you, this is something that I learned only through the GINA 2026 document. If your pressurized meter dose inhaler is a solution, then nothing to worry about. Whether you shake the inhaler device or whether you don't shake the inhaler device doesn't make much difference. But if your pressurized meter dose inhaler is a suspension, all pressurized meter dose inhalers excepting Nivioli, which is salbutamol, so which is beclomethasone formoterol, all the rest are suspensions. Now see what happens when you have a suspension, and here is budesonide formoterol. Let me just show you the pointer. So this is the canister life. So you start with the inhaler, and then as you complete, you use more and more doses, what happens? Now, because the budesonide formoterol suspension stays on the top, all the initial doses will only be the propellant. Very little dose of budesonide formoterol goes until you finish more than 3/4 of the inhaler. This is if you don't shake. And at the end, you will get such high doses of budesonide formoterol that is going to be a problem. In the beginning, you don't get adequate dose. Later on, you get very high doses, about 3 to 5 times more than the recommended doses. And this is because the suspension, you can see budesonide formoterol, it floats on the top. In contrast to that, if you have a salmeterol fluticasone suspension, the salmeterol fluticasone suspension goes at the bottom. And if you don't shake this inhaler well, then the initial bits of your inhaler will give you very high doses, of the salmeterol fluticasone. And as the inhaler gets the number of actuations they increase, then the subsequent doses become less and less and less. Now, this tells a very important message. If your inhaler is a suspension, please shake it well every single time before you use the inhaler. Now, here is the data that shows what happens if there's a delay from shaking and actuation. For a suspension, it doesn't make much difference. So 10 seconds, 30 seconds, 60 seconds. Look at the difference it makes in a suspension. If you have shaken the inhaler and if you forgot about it, took the inhaler after 30 seconds or after 60 seconds, there is a significant reduction in the dose. Similarly, in salmeterol fluticasone, if you've not shaken the inhaler, then you can see that you get with delay in the shaking, your dose emitted is very very high. So please keep this at the back of your head as a very important new learning for all the postgraduate students. Remember that all inhaler devices, excluding beclomethasone formoterol, all of them are suspensions. So I'm going to stop over here. Here is the the site where you can take a picture. You can open the site, and yeah, you'll get all the strategy reports, the slide sets for GINA 2026. I'm going to stop over here, and I hope that I have managed to give you a lot of new information, which even I did not have until very recently. So over to you, Dr. Monica. Thank you.
Yeah. Such a wonderful presentation, sir. So many new insights from Gina, and you put it so lucidly and so beautifully with evidence. I'm sure, like, it is going to stay with all of us who listen to your talk. So thank you so much for that.
Thank you.
I
Thank you.
would I would now like to invite Dr. Bhattacharya ma'am to take us through the what are the evolving concepts on MART therapy in children or MART strategy in children. Over to you, ma'am.
Thank you, Monica. So let me share my slides. Is that visible?
Yes, you need to put it in slideshow.
Is that all good?
Yes, yes.
Okay. So good afternoon, everyone. Um, Dr. Salvi mentioned MART on and off during his talk, and he also said how nasty only Saba can be. So I am going to take you through some of the studies, but very rapidly because there is so much of ground to cover. Then why are we talking to postgraduates in pulmonology on strategies in children? Because as chest specialists, a lot of parents would come to you when their child have repeated respiratory symptoms because you are the chest doctors. So it's good for you to also know, but we are talking about MART because it kind of goes beyond 6 years onwards. And that came in 2022 because younger than that, I think till 5 years, they would still be more comfortable first coming to the pediatrician. So, of course, MART that you will need to use is only 6 years and beyond. I need to tell you this, that bronchial asthma is the commonest chronic disorder of childhood. We hear of 35 million asthmatics in India. Every other asthmatic is a child. And as Dr. Salvi has told us, that it's a heterogeneous disease. All the symptoms are so different. So, and that there is a lot of variability, and the symptoms is because of inflammation in the airway. That is why this year Gina is so strong about anti-inflammatory medication is like a birthright of any asthmatic because asthma is a chronic inflammatory disease. And what are the symptoms has been already told to you: cough, wheeze, shortness of breath, chest tightness, and variability has already been discussed, and that there is expiratory airflow limitation which is reversible. Hence, Dr. Salvi told us about the importance of reversibility, and which GINA 2026 has come on very strongly, and it's recommending that we must look out for reversibility in spirometry, or where not possible, in a peak flow meters. So I'll show you one of the cases later on how that was like a wake up call to use MART. So, goals. What is MART? It's treatment, right? It is maintenance and reliever treatment where we're using the same inhaler. When I go about treating a child with asthma, there are certain goals. A is to achieve good control over their symptoms, to maintain normal activity level. Like a child should be able to play, should be able to go to school. Did you know that bronchial asthma is the commonest cause of school absenteeism in childhood? Then, while we are doing all this, we have to see that we don't give too much of side effects with medication, and that our children don't land up in flare up. A side effect of drugs can be overuse of drugs by not knowing the dosage, or by needing oral corticosteroids if you're not controlling them well. So a lot of side effects and risk can be because of those drugs. And while we go about treating asthma, we need to maintain lung functions, lung development, because if we pediatricians, or if you treat children and you're not doing that well, then their lung growth is affected, the airways get remodeled, and these are pretty certain to become adult asthmatics or adults with COPD. And what is that last box is my addition when I always speak to my parents, that is to gift a near normal life. A child, an asthmatic child, should be like any other child and not be under the threat of an impending attack. Now, there is a lot of change in our thinking. Once upon a time, we used to think asthma is everything to do with bronchoconstriction. That's why a lot of our language, Indian languages, it is to do with breathlessness. So you would say dama in Marathi, or dama again in Hindi, or in say Bengali hapani, meaning breathlessness. But later on came the concept that it is just not breathlessness, these airways are probably hyperresponsive. Then they said these hyperresponsive airways are actually airways which are chronically inflamed. So, chronically inflamed, not treated, can also get remodeled. That's when the lung functions get affected. And at this point of time, there is a lot of talk on phenotypes and endotypes of asthma. That is where we are directed in the future of precision medicine. Now, pillars of asthma pharmacotherapy controllers are ICS plus LABA, LAMA, LTRA. Relievers are SABA and anticollagen. And so we have either the beta agonist, short acting, or we have the anticholinergic. We sadly don't have it separate, ipratropium, which used to be available once upon a time. We now have it in combination. And AIR, which Dr. Salvi told us many a time, which is something that we mustn't forget, that can be ICS plus SABA or ICS and a rapid acting LABA. So, what is MART? You may be wondering. Dr. Salvi showed us MART in his slide, and now there is again MART. The whole talk is on MART. So, what is that? MART is maintenance and reliever medicine in one inhaler. How lovely is that? Because it'll simplify management. And what are the medicines in MART? So, if anything has to work as a reliever, we need it to have quick onset of action. So, it is ICS plus formoterol. Now, you might say that which ICS? Most of the studies, whether Trexa, Sigma, they're all done with budesonide and formoterol. Hence, we go along with budesonide and formoterol. You might say, what about the other ICS? Why is there so much of talk on budesonide? And of course, in our country, we also have combinations with other drugs, but basically, it is still not cleared in many countries because of regulatory endorsements, and there is a lack of strong evidence that is it okay to combine fluticasone and cyclosinide with formoterol. Now you know that there are two LABAs, right? There are three LABAs, but we mainly talk about salmeterol and formoterol. And so why is salmeterol not? Why are they only talking about formoterol? That is because salmeterol has a longer onset of action. Hence, it cannot be a reliever. When you're relieving a shortness of breath or a tightness in the chest, then you need something that needs to work fast. Now, just to tell you, I won't go into the details because I have a lot of ground to cover, that formoterol is a selective long-acting beta-2 agonist. And the beta-2 receptors, it works 200-fold activities are there. It has a very fast onset of action. And how does it act? By bronchodilation, by reducing the plasma exudate, by mast cell stabilization, and by reducing the neutrophils too. Now we can leave this slide and let's get on here. So you see, I'll minimize the whole column up here so that I get to see it too, is that if you see, there is formoterol, the blue one, salbutamol gray, salmeterol orange, and the placebo is green. Are you seeing that salbutamol and formoterol? Now we all think that salbutamol is the great reliever, but the quick onset of action within the first 3 minutes is also formoterol. So how brilliant it would be if we can combine it with the ICS. Now, why isn't the slide moving? Okay. So now we go on to this study where they had studied more than close to 3,000 people, and they saw, and they were given budesonide plus SABA. Budesonide, SABA was the reliever, and budesonide formoterol as maintenance, and SABA as reliever. And it used to be then called SMART because they'd use Symbicort, and that was the same as budesonide and formoterol. And they found that the risk of severe asthma exacerbation was 45% lower with budesonide formoterol as maintenance and reliever versus budesonide formoterol as controller and SABA as reliever. And if you see that if you increase the budesonide 4 times over, it just comes down by 47%. That's the plateauing effect of the ICS. Why is it getting stuck? I'm kind of...
Can you use the arrow that's there on the left-hand corner below to go to the next slide, please?
Where?
Yeah, just
This
little
one?
down. Yes.
Okay, super. Thanks for that.
You're
Okay,
welcome.
so let me... Does this arrow move backwards also? Yeah, great.
Yeah.
So this is so basically it needs to have my picture up there. At the moment I knocked that off, it started misbehaving. So there is this facet study which said to evaluate the effect of adding inhaled formoterol either to low dose ICS or higher dose. So they had budesonide 100 BD, budesonide 100 BD plus formoterol, budesonide 400 placebo. So it was like a double blind study, and 400 plus formoterol. And look at it, both in the severe exacerbation and in the mild exacerbation, there was significant improvement in both day and nighttime symptoms besides the exacerbations. But more than this is something that I need to show you, is that where is it acting? When you have a person coming with signs of early warnings of a flare up, if you ignore it and you reach up right on top, you will end up needing oral corticosteroids because they've come breathless into the ICU. However, if patients intervene when symptoms are bothersome with budesonide and formoterol, this is what happens. They are coming in early to manage their mild flare up. It doesn't reach the stage when you need oral corticosteroids, and the recovery is also much faster. Now, this is the CARE study, which is very much for children. So, though it was not a huge study, but it was a very important study because they studied in children 5 to 15 years. And it was doctor diagnosed, and where they were using SABA as reliever initially. So, which were the children who fulfilled the criteria? SABA used 3 or more consecutive days in the last 12 months. Well, all our kids would be in that. SABA use at least 2 days per month. Urgent medical review, like racing into the emergency, or worsening asthma in the last 12 months. So they were either given budesonide formoterol 2 puffs or they were given salbutamol 2 puffs. And this is what was found, that the number of attacks in the budesonide formoterol was 45 versus 80 in the other group. And as pediatrician, what was very, very important for us to know is that the growth velocity, a lot of parents are worried about that, will my child grow well because he's on inhaled corticosteroids? And if you keep escalating inhaled corticosteroid, you might hamper their growth. And this is very important for you pulmonologists also to know that this is predominantly more in girls around menarche. This is what Dr. Salvi mentioned, that no SABA anymore. But this actually came in GINA 2019, and this was path-breaking for us pediatricians a lot, because before that we were using SABA as reliever. It's still used in under 5 as reliever, but now 6 to 11 years onwards, like especially GINA 2026 says, even in 6 to 11 years, it is AIR which is the reliever and no more SABA. So SABA alone, he's already told us this. So probably I can jump that and tell you that why no SABA? Because it downregulates the beta receptors, decrease bronchoprotection, there is rebound hyperresponsiveness, and there is decreased bronchodilator response. And there is increased allergenic response because there is pouring of eosinophils in the airway. And if we keep using SABA more and more, there is a higher risk of these patients landing into acute exacerbation. So earlier there was a thing called mild asthma. Now we know that most of the ICU admissions are mild asthma because they are just doing the relievers on and off, so that we forget all that and take it off our syllabus, and we only use AIR, which Dr. Rajadhar is going to tell us more about. That is why it is like now whipping that let go of SABA, because you might push patients into crisis because they are not understanding what to use. And therein comes the importance of MART, because maintenance and reliever therapy is through one inhaler. Now, unlike you adult doctors, we are all adults, but adult doctors, as in doctors treating adult population, we pediatricians have to know multiple doses. So children 6 to 11 years, low dose, just remember 200, 400 and more than 400. And in adolescent and adults, which you have, 400 low dose, medium dose 800 and higher dose is more than 800. Like Sandeep was saying that like now they've gotten a little guarded with both step 3, step 4 going as low dose and switching on to medium dose on the higher, because probably also since there is smart, there is steroid sparing and it is not ICS plus LABA. Now, if you have to choose a LABA, better for us to choose formoterol. Now, this is GINA 2026, launched on the evening of 5th, and we are on the 8th today. So this is just 3 days old. I'll take you one by one. So if symptoms are 2 days a week or less, AIR alone, or as needed low dose ICS formoterol, or as needed low dose ICS plus SABA. Now, if symptoms are 3 to 4 times a week, then it is better to give a daily low dose ICS, because if you give on and off, they've seen that the level of control may not be so strong and good. That was part of the TREXA study. Now, step 3 is where MART makes an entry with background score, and we are ever so happy about it. So symptoms on most days, and there is night awakening because of symptoms, or there may be low lung function that is less than 65% FEV1 at onset, then you have all these choices. But you see that a very smart choice is SMART, where it is low dose ICS plus formoterol, both maintenance and as well as reliever. Low dose, as I said, is 200, medium dose is 400, and more than that, high doses more than 400. And believe you me, we rarely need to use more than 400. And again, just in adults, which Dr. Salvi said, that here also in step 3 and step 4, they've stuck on to low dose. This is a change in GINA 2026, going a little conservative and teaching us good techniques. And step 5, which we rarely use, because in this age group, I have not even needed, except for one kid whom I needed to use LAMA, but otherwise most of them get controlled. And once we thought that we might need to shift one child onto omalizumab, but we could identify the trigger and that kid, we spared the expense and the trauma of injectables. I don't think I will go through this because Dr. Salvi discussed track 1 and track 2 in details, but just to show you that what a brilliant slide Dr. Monica made for CASPA, which is the training program for pediatricians when we teach them bronchial asthma. And a lot of our children, because as pediatricians, we see them from birth till 18 years, and a lot of asthmatics, even beyond 18, sometimes prefer to stay with us. But of course, we are keen to get into transition medicine and shift them on to pulmonologist who feels as passionately for asthma. And so just look at the beautiful tracks that meet at step 3 that she made for us. I'm not going into details of it because Dr. Salvi has explained to us track 1 and track 2 very well. So that will save me some time and I can take you through cases. So Ashish is 8 years. I'm purposefully choosing 2 cases in the 6 to 11 years and not doing the adolescents because you would manage them the same as adults. Ashish is 8 years of age, a boy, strong family history of atopic and asthma. He's been symptomatic since 4 years. Parents were resistant to daily budesonide given twice a day. Resistant is not resistant to drug, but resistant to taking. They felt it was habit forming, so he routinely would miss doses, so he remained partially controlled. And they would use the blue inhaler pretty regularly because it worked better. So for them, it was all about symptom control. One day, prior to Diwali, where there was a lot of cleaning and there's a lot of firecracker and pollution in our part, uh, he felt tightness in the chest and breathlessness. He was nebulized. They had a nebulizer at home. The entire family is using the nebulizer whenever they have cold cough. And he got worse. He was taken to the hospital. He was hypoxic because he was desaturating. He was admitted in the PICU and he had a stormy stay and he was discharged after 3 days. And that's when they were referred to me. So the concerns of the patients were that he's asymptomatic on most days, but he returns home breathless after games. He suffers with the blue inhaler, so we thought it's okay, and hence we were not using the pink inhaler regularly because we didn't know its importance. We just thought asthma is that if he gets breathless and if after games, if this was helping him, we were okay with it. So we counseled them. We told them about what is an inflammatory disease by using the breath tubes and then prescribed MART. Explained to them, the family, the doses, the timings, the extra doses that can be used if there is increase in symptoms, the maximum number of doses, and how to monitor with a peak flow meter. Maintain an asthma diary, regular follow up with the device to check technique and adherence. Each time, every time, this was checked. So asthma doesn't finish by a eureka moment of diagnosing and giving them the great drug. Yes, smart is great, but a lot goes into when, how many, how much, how to give, how to monitor, and how to do a follow up regularly. He remained well controlled. The blue inhaler was not needed, and he has now been stepped down on treatment. Now, the second is a very recent case. Inaya is 6 years of age. She has been on budesonide, 100 microgram, 2 puffs twice a day, and Saba SOS. Okay, because under 5, that is like the dictum. So she's now 6, and of course, she was due for a step down. And I also thought that now she's very good to do her spirometry. So we will also see, and we need to have like one documented thing of our lung functions. So parents said, yeah, she's quite good on. She's been doing very well, and they were looking forward to the spirometry and looking forward to the step down. And when we did the spirometry, there was a bronchodilator, reversibility. Of course, there was obstructive airway disease. Her FEV1 by FVC was way less than 90. And there was a significant bronchodilator reversibility in the 20s. Reversibility it's a real mention in 2026. Reversibility, which we pediatricians have been saying a lot, that you may get a normal FEV1 by FVC, but reversibility is a hallmark. And this is where we saw that she was boom. And that is when I said that her spirometry is not showing the way you tell me good control. And therein came out the secret that in the morning, giving 2 doses of budesonide was becoming a time crunch. So what they were doing, so that she doesn't get into any problem, they were giving her one blue dose, at least it's one dose in the morning and sending her to school so that she's all good. So they said, now that it's holiday, we can give her. But during school days, it is very difficult to give her two puffs. And that is why we used to give her the blue. Then we knew that, the effect lasts for a long time, 8 hours. And then till she returns, she'll be fine. And at night, we would give her the pink. Wake up call for all of us. Wake up call, most certainly for pediatrician. Wake up call for me too. So I switched her for a formoterol budesonide, pardon me for mentioning that, and one puff and another puff SOS. Mart endorsements. Gina was the first one that really started speaking about Mart. And Gina got Mart into our pediatric basket in 2022. Then the National Institute of Health and Care Excellence, NICE, took another year to accept it. The British Thoracic Society accepted MART in pediatrics late 2024. Then the Canadians, then the ERS, then the Australian handbook gradually, and the ATS, I don't know. Dr. Salvi will be able to tell us better. I don't think they still come on fully on MART, but the Association of Allergy and Immunology, and they have endorsed MART. Now, how many puffs Dr. Salvi has already shown us. We used to teach this even before GINA 2026, that 11 and above, the total of 12, because of a cutoff of formoterol 72, because we have a fixed dose combination of 6, and ICS can be low dose, medium dose, and 6 to 11 years is 8. So you saw that the children, both Ashish and Anaya, like they were told that if you feel that you need, but if you reach 8, you definitely need to reach your doctor. But I've been using since 1922, so it's nearly 4 years of using MART and have not really needed. And you need to document it in the asthma action plan. My last slide. What are the benefits of MART? It simplifies treatment plan by combining maintenance and reliever therapy. So we are planning, it makes it easy for us and it makes it easy for the parents to understand. Because they understand better, so their adherence to treatment and asthma control is better. And as you already know, that it reduces the reliance to short-acting beta agonist. I've already shown you in 2 genuine cases from the clinic. And all the studies, it shows that it reduces severe exacerbation. That is why it was taken in and SABA was phased out. Thank you so much for listening to me. And I hope we together will help our children with asthma control it better. Thank you. I'm stopping sharing.
Thank you so much, Dr. Barnali, for an absolutely brilliant presentation. I think it's such an important component of asthma management, isn't it, Mart?
True, true.
Now, I'm aware that you need to go, you're going to be busy with something else. And therefore, quick questions.
You can take the questions because I haven't got landed as yet.
Okay, okay, okay.
So I'm sorry I'm sorry to interrupt, sir, but we've got time for one question.
One question.
We are quite delayed. That's why.
Okay.
Yeah.
Okay. And if I can ask that, Dr. Barnali, is
Yes.
cough variant asthma in children, is there a role for MART in that?
Yes, there is a role for MART in that. But
So these are children
there's
who will be present with cough?
Yes, so we have a lot of children, even under 6 years, who may present only with cough. So there I would do a trial of ICS. So I would give it for 3 months, communicate with the parents, and if after 6 weeks I get no response, I would start investigating as to is it an atypical condition. But before labeling it as a covariant asthma, I would go into details of history, that is there
Sure.
any variability, and is it related to running, crying, laughing? Is there diurnal variation? Is there seasonal variation? So it's just not
And
cough but variable.
and if the therapeutic trial works, then you
Then
would
I
put
will
them on
then I
MART.
will label it as asthma. And if it's
Okay.
under 5, I won't put it as in MART. I will do ICS and SABA. But if it is 6 years and above, I can either use as, you know, like AIR in step 1 and step 2. But you see, in step 2, they say ICS gives you better control. So if it is on and off, I would probably say, okay, let's give it for some time and see. And if I see it's all gone, I will keep it under surveillance, because children, we have to be so careful about just giving them any drugs. But
Yeah.
if they are in step 2 beyond, yes, why not?
Okay, great. Thank you so much. I think in the interest of time, Dr. Madhura, I think we can go ahead with the next steps. Yeah.
Yes. Thank you, Banali ma'am. That was a brilliant presentation.
Thank you.
Very clearly put forth about MART for our pulmonologists who are watching from the pediatric angle. So thank you, ma'am. Unfortunately, with the interest of time, we will have to move on. So thank you for being here, ma'am. Next, I would like to quickly invite Dr. Rajadhar sir to take over and talk about the anti-inflammatory reliever component of the management. Over to you.
Yeah, so I'll just share. Absolute pleasure, privilege to be a part of the Purview program again. So I wanted to thank the team on two accounts. One is the fact that Dr. Salvi now represents India and Asia on the Gold and the GINA guidelines is a pride for all of us, all of India and all of Asia. And the Purview team, my trainees, look forward to this program, and being a part of it is a huge plus for them. So thank you for arranging this program for the trainees, for the young pulmonologists throughout the country. So my ambit today, I have been given the remit of talking about anti-inflammatory reliever therapy in the context of the current GINA guidelines. Are my slides visible to all of you?
Yes, they are.
Okay. So a lot of what I am going to say, probably all of what I'm going to say, has been said already. However, I think a lot of what I'm going to say needs reiteration, which is probably what makes the talk relevant. I'll try and finish in about 18 minutes, and then we can be back on track and take some questions in the end. So these are the learning objectives for the audience who's listening in. By the end of these 18 minutes, we'll define anti-inflammatory reliever therapy and the mechanism of how it works. We'll talk a little bit about why SABA treatment is no longer recommended. We will identify the 2026 treatment tracks and the expanded AIR concept. So embracing the fact that ICS SABA is also a part of anti-inflammatory reliever therapy, along with ICS formoterol, which has been a part of AIR now for a few years. We'll apply AIR in track 1 across the 5 steps. We'll recognize the role of anti-inflammatory reliever in exacerbation. That's something which is new. And we'll mention the Batura trial again, which Dr. Salvi spoke about. And we'll talk about managing asthma exacerbations and step down using AIR strategies. So that's what we're going to do over the next 18 odd minutes. So why are we talking about asthma? Why do we have a World Asthma Day? Why does GINA launch guidelines on an annual basis? The reason is on that slide in front of you. A huge load of asthmatics, about 12% of these 300 million worldwide asthmatics are from India. 96% of asthma deaths and about 45% of asthma deaths come from India. 96% of asthma deaths come from low and middle income countries. And 25 to 35% of patients who are diagnosed with asthma actually do not have this disease. So a lot of underdiagnosis and a lot of overdiagnosis happens in this country. Why are we coming off SABA and again, you heard Dr. Salvi and Dr. Barnali Bhattacharya mention this in some detail, but just to reiterate, SABA-only treatment results in increased exacerbations, poor lung function, and this translates into greater mortality. And there's some numbers which were quoted about 5 years ago now from the GINA guidelines. If you have more than 3 canisters of SABA used in a year, which amounts to about 200 doses, it significantly increases exacerbation risks. If you have 1 canister a month, hence more than equal to 12 canisters per year, that is a marker for mortality. It causes increased number of asthma deaths. Regular SABA use increases airway inflammation and reduces bronchodilator response, and use of nebulized salbutamol at home is associated with increased asthma deaths. So that underlines the SABA reliever problem that we have. So this slide shows you the evolution of the asthma treatment strategy. Things changed in 2019. Pre-2019, it was SABA as the rescue medication used as and when required, and this was the only reliever for symptoms. Come 2019, the Sigma trials happened. The Sigma 1 and Sigma 2 trials happened, and this showed that ICS added with every SABA dose resulted in reduced mortality, better symptom control, and lesser progression of asthma. Between 2020 and 24, ICS formoterol was recognized as being a potent reliever medication, and the AIR concept was introduced at this stage. And in the last 2 years, 2025 and 2026, anti-inflammatory reliever is thought to be universal for all adults. You've heard this a few times through today, and I'm sure even before that. And ICS SABA has also entered now the arena as a part of anti-inflammatory reliever in track 2. So there's been a paradigm shift, and the shift is twofold. One, for treating symptoms, and second, in preventing exacerbations. So the old thinking of SABA-centric treatment, which all of you know, so use SABA whenever there are symptoms, use an inhaled corticosteroid separately, use a controller, more SABA equals better symptom control, and the fact that in mild asthma, GINA 1 asthma, GINA 2 asthma, you don't need an inhaled corticosteroid, you just use the salbutamol, is a thing of the past. The new thinking, so shift from SABA-centric treatment to AIR-centric treatment, says that you use ICS formoterol to treat inflammation and bronchospasm concomitantly. Single inhaler does relief of symptoms and prevents progression of disease, prevents happening of new symptoms. More SABA is a danger signal. Then switch to AIR or MART. In fact, the modern thinking is you shouldn't be on a SABA in the first place, let alone use more of it. You should always be on anti-inflammatory reliever. And no patient is too mild for an inhaled corticosteroid. So even GINA 1 needs to be on an ICS. And the reason is that even the mildest of asthma can have a fatal attack of asthma. And we all know of percentages where GINA 1 and GINA 2, the mildest form of asthma, can have a fatal attack of acute severe asthma. So what's anti-inflammatory reliever? And we'll do this quickly because we've done it a few times today. So anti-inflammatory reliever is any inhaler that is used as a reliever instead of SABA and has an inhaled corticosteroid in it. In GINA 2026, we have talked of 2 anti-inflammatory reliever therapies. There's ICS formoterol in track 1, and you've heard a few times that that is the preferred treatment across the board, across GINA stages. And then you have an ICS SABA, which is in track 2 and is the backup. It is the alternative. So when we talk about the ICS component, we talk of 2 steroids. One is budesonide and the other is beclomethasone. And all of you know the ICS component in asthma reduces airway inflammation, it prevents exacerbation, and it improves lung function. The formoterol component, the LABA component, what makes formoterol special, the reason we keep talking about formoterol rather than any other LABA is because of the rapid onset of action, as rapid as a SABA would do. So rapid bronchodilation, and can be used on an SOS on a PRN basis. And combining, put these two together, put the ICS and the formoterol component together, you treat both inflammation and bronchoconstriction with every puff. So whenever you use an inhaler, every time you need a reliever, you have the ICS and the bronchodilator together. I have put in some exam tips at the bottom because this is purview, and I want the examinees to know that the GINA 2026 update now includes the SABA as an alternative to ICS for formoterol in track 2. So that's something you remember. So it's when we talk about anti-inflammatory reliever, we just don't talk about the ICS and formoterol. We also talk about ICS SABA. And ICS formoterol, however, is the only option for MART. So both ICS and SABA and ICS formoterol are anti-inflammatory reliever. However, for maintenance and reliever therapy, you still are talking only about ICS formoterol. And other bronchodilators like salmeterol cannot be used as relievers. ICS SABA also reduces severe exacerbations by about 50%, which is the Batura trial, which we'll talk about again. So why anti-inflammatory reliever works better than SABA alone? So whenever you have symptoms triggered, you use a short-acting bronchodilator. You heard the lovely cases Dr. Bornali Bhattacharya spoke about, where the first kid used to use SABA. The parents used to encourage the use of SABA because they reduced symptoms, ameliorated symptoms. So bronchodilation happens, there's reduction of wheeze. Underlying inflammation, however, is untreated. Hence, the mast cell and eosinophilic cell overactivity continues. There's repeated inflammation, there's airway remodeling, there's more symptom, there's more SABA use, and you go into this vicious cycle of tolerance and worsening. So that's a vicious cycle. Think of what happens when you take anti-inflammatory reliever, which is a combination of an ICS and formoterol. You have symptoms triggered, you use an anti-inflammatory reliever, the bronchodilator component causes bronchodilation, the ICS component reduces inflammation, the mast cell activity, the eosinophilic activity is reduced, suppressed, and there are fewer subsequent symptoms. And there's lesser need of reliever over a period of time. I have named this as the virtuous cycle because control improves. It's a vicious cycle on one hand and the virtuous cycle on the other. The next thing I want to speak about is the two tracks. So track 1, which is ICS formoterol all the way in the form of anti-inflammatory reliever, and then track 2, which is ICS SABA now, again in the form of anti-inflammatory reliever. So again, this has been mentioned a few times. This is the adults and adolescents. So the reliever and the maintenance therapy being the same, step 1 and step 2. You would use anti-inflammatory reliever only. Step 3 and step 4, you use the same inhaler, both for maintenance and for relief. And step 5, you have add-on treatment. And the advantages are intuitive. It's the single inhaler for all steps. You're always delivering the ICS, which ameliorates inflammation. You reduce exacerbations compared to using a SABA itself. And it's a simpler regime, better adherence, using the same inhaler. So it's, again, a no-brainer to understand that compliance would be better, the patient's technique would be better, and acceptance hence would be better. Track 2, or the alternative pathway, is using an ICS SABA, so budesonide plus salbutamol as anti-inflammatory reliever. We have said a few times through the meeting today that this is something which is new in GINA. Step 1 would be an ICS and SABA on an as and when required basis. Step 2 would be a low-dose maintenance ICS by itself. So no bronchodilator there. The ICS SABA would be the rescue. Step 3 and step 4 are ICS plus LABA in varying doses. So in step 3, you would have a low dose. In step 4, you have a moderate dose of ICS plus LABA. And you have the ICS plus SABA as the reliever medication. And the use of the alternative pathway, I think, is difficult in countries where you have both available, as in a formoterol ICS available and also a SABA ICS available. but you might want to use it when ICS formoterol is not available. When a stable patient is already doing very well on this track, you might want to continue it. And if the patient for some reason has a preference for track 2, they might prefer this regime. To me, however, track 2 is just a backup plan. A majority of my patients, and I think my colleagues' patients worldwide, are actually on track 1, which is the preferred pathway. So ICS SABA's anti-inflammatory is based, like we said, on the findings of a trial which is called the Batura trial, which was a randomized controlled trial which looked at budesonide salbutamol versus salbutamol alone in adults with mild to moderate asthma. The key findings of this trial, the reason it's come into track 2 as the treatment of choice in track 2, is because there was a 50% reduction in severe exacerbations compared to SABA itself. It improved symptom control and quality of life. It's particularly relevant, like we said, when ICS formoterol is unavailable or in some countries unaffordable. So ICS SABA is not MART. Remember, we've said this once before. So ICS SABA is not maintenance reliever therapy. Only ICS formoterol can be used as MART treatment. So this is the GINA step ladder. I've presented it as a table for convenience, but you saw it as a step ladder in Dr. Salvi's talk. So step 1 and step 2 of GINA does not have a maintenance. It's low dose ICS formoterol as and when required. Step 3 is a low dose ICS formoterol twice daily, and the same ICS formoterol to be used as reliever. Step 4 is a medium dose ICS formoterol twice daily, and the same ICS formoterol used as a reliever. And step 5 is when you phenoendotype patients, when you add in a LAMA, you consider biologic treatments. That is when step 5, you phenoendotype patients and you continue to use a low-dose ICS formoterol on an SOS basis. The key principle in track 1 is the same inhaler being used both as maintenance and as reliever. I keep hammering this. Others have done the same. Make sure that an ICS goes in whenever a patient takes a puff of inhaler of any sort, irrespective of how mild the disease is in our patients with asthma. What about step 3 and step 4? So step 3, you remember, are patients who have symptoms most days on waking up or symptoms more than once per week or with a low FEV1. 1 puff of budesonide 200/6 twice a day is the dose. 1 puff of the same inhaler is SOS. The maximum number of inhalations, both for step 3 and step 4 MART, is 12 inhalations, like you've heard before. And ICS dose delivered is low dose ICS as maintenance with as and when needed doses. The advantage, like we have said, is fewer exacerbations and comparable symptom control. Remember, the symptom control is comparable. It's the exacerbations which are fewer. And step 4 is patients who have daily symptoms, waking up more than once per week, low FEV1, and even current smokers are in step 4. The dose here is doubled. It's 2 puffs of budesonide formoterol, the same SOS dose, the same number of maximum inhalations for reliever therapy. And the ICS dose delivered here is higher, so medium dose ICS. And again, the reason, the rationale for doing this is fewer exacerbation with similar symptom control. So these are the dosages. Again, Dr. Barnali Bhattacharya and Dr. Salvi have said this time and again. The 6 to 11 years of age, the maximum number of formoterol budesonide doses is 8 puffs. Look at the strength of the formoterol budesonide here. It's 100/6. Or if you're looking at an equivalent, it's 80/4.5. 12 to 17, it's 12 puffs. The strength doubles. So formoterol budesonide 200/6 is the dose advocated. Above 18, formoterol budesonide 200/6, whether it's a DPR and MDI, or if it's beclomethasone formoterol, it's 100/6, a DPI or an MDI, and again, a maximum of 12 puffs. I won't go through this. Dr. Barnali Bhattacharya has gone through it in great detail. Remember, there's still a mention of a leukotriene receptor antagonist as alternative control in step 1 of GINA. So LTRA is still in the guideline, just about. I think maybe 1 or 2 GINA guidances in 2 years. Probably this will exit even as alternative control. And remember that GINA 1 and GINA 2, it's about anti-inflammatory reliever, but maintenance and reliever same inhaler is not yet for GINA 1 and GINA 2, but from GINA 3 onwards, even in case of children. The last few slides, so implementing anti-inflammatory reliever in practice and starting, adjusting, and stepping down is what we have said. So a patient has a new diagnosis of asthma and is an adult or an adolescent above the age of 12 years. If ICS formoterol is available and if the patient can adhere, we look at symptom frequency and severity. This helps us to define the severity and the step of GINA these patients are on. Once you've defined it, track 1 is anti-inflammatory reliever therapy all the way. Step 3 and step 4 are about the same maintenance and reliever therapy. Track 2 or the alternative pathways, step 1 and step 2. Step 1 is about a SABA and an ICS as and when required. Step 2 is a low dose ICS plus a SABA as and when required. Step 3 is a low dose ICS LABA. And then step 4 is a medium dose ICS LABA. And stepping up and stepping down, this table tells you when to do it. Again, I won't go through this entire slide, but suffice to say that you step up when symptom control is poor despite correct inhaler use. And the second big area is the risk of exacerbation being present. And there's a table in this GINA guidance and also in the 2005 as to what the risk factors are for exacerbation prone asthma. Make sure the patient has correct inhaler technique, make sure there's not poor adherence, make sure comorbidities have been addressed. And you step down conversely when there's good asthma control maintained for a period of 3 months. I read this intentionally as 3 months. The last GINA guidance talked about this for 3 months. And that's what I do in my practice. When there's no respiratory infections, when the patient is not traveling, there's no pregnancy, you don't want to be stepping down in a pregnant lady. When there's low risk factors for exacerbation, what you would do is to reduce the ICS dose by 25 to 50% and change to a lower strength. See what's written in bold, that's important to remember. Never completely stopped inhaled corticosteroids in adults or adolescents where symptoms and a spirometry shows asthma. Never come off the ICS completely is what the guidelines say even today. I've put another exam tip in there. So when you're stepping down in track 1 of MART, reduce maintenance puffs. So step 4 goes to step 3. 2 puffs twice a day becomes 1 puff twice a day. The reliever always remains the same. And you would get this in your MCQs. Never stop inhaled corticosteroids completely in adults. In uncontrolled asthma, make sure you check adherence. That's 1. Second, inhaler technique. Comorbidities is 3rd. Looking for triggers is 4th. That's a chart that you need to go through before you step up in your patients. Step 5 is difficult to treat asthma. And here, this is asthma which is uncontrolled despite good adherence to medium or high dose ICS LABA. You've added in the LAMA in these individuals and you phenoendotype here. And depending on whether the patient has severe allergic asthma, so atopic, or whether the patient has severe eosinophilic asthma, or whether the patient has paucicellular or neutrophilic asthma, there's various biologics which are available, which you might want to use. I'm not going to go through the biologics theory here. That's not the point of this talk. However, one exam tip again, tezepelumab, which is an anti-TSLP, is approved of all severe asthma phenotypes, regardless of the eosinophil count, and hence is unique. And dupilumab has a contraindication attached to it if the blood eosinophils are more than 1500 plus microliter. So remember these 2 facts about tezepelumab from an exam perspective. So tezepelumab, all asthma phenotypes, dupilumab contraindicated if the blood eosinophils are more than 1500. This is just a reminder. That's not something which is changed. But remember about asthma action plans, that still remains a strong recommendation from GINA, always has done. So green is good control. You're happy with your patient. They are on usual medication with minimal symptoms, with the peak flow, which is more than 80%. And you would continue your usual air MART treatment as prescribed. Yellow is warning signal, so it indicates worsening symptoms. So you increasing symptoms with a peak flow of 60 to 80% rather than above 80 means more relievers are needed. Increase the ICS for metrol in these patients. If you're using track 2, then the ICS SABA needs to be given to these individuals, or the maintenance ICS needs to be quadrupled in these individuals. And if not improving, you need to seek medical attention quickly. The red is things going downhill very quickly, peak flow of less than 60%. You would use the ICS formoterol as needed up to the maximum. So remember, 12 puffs was the maximum. You should start steroids in these individuals, both adults and children. And it's important that you go to the emergency then and there. There's no question of waiting. And that's why these action plans are so very valid. Another thing which is new are these different charts for exacerbation management. There are 4 different charts that have come in for exacerbation management. I've only put in one, the one for primary care. All of you know these classifications. The mild, moderate in one category, the severe in the second category, and the life-threatening in the third category. The reason I've put up this slide in an anti-inflammatory reliever talk is look at the mild, moderate category. It's always been about SABAs till date through an MDI or a spacer or even a nebulizer. However, the GINA 2026 guidance talks about ICS formoterol as an alternative reliever every 20 minutes into 3 doses in the mild to moderate category. So that's another aspect of air therapy, the anti-inflammatory reliever therapy, which is worth remembering. The management of severe and life-threatening asthma remains the same. And I'm not going to talk you through this, but important that you remember about a home care package and also about exacerbation management. And that's been underlined in these guidelines. What about the post-exacerbation discharge plan? So the checklist that we have, and the first one is the most relevant to this talk, prescribe the ICS containing maintenance. So for adults and adolescents, that's going to be an ICS formoterol. And if that's not available, a daily medium dose ICS LABA would be prescribed, and similar for children. Reduce reliever to as and when needed only. The asthma action plan should be in place. The oral prednisolone course remains for 5 to 7 days. And if the steroids are being given for less than 2 weeks, there's no need to taper. Check inhaler technique and adherence, and follow-up appointments should be given in a week's time in children and adolescents, or even earlier if the asthma is not fully controlled when you're discharging the patients. The very end, the 4 key points, populations, special populations that need to be remembered are pregnancy. So in pregnancy, continue the ICS throughout pregnancy and never stop. ICS and beta-2 agonists do not cause fetal abnormalities. The monitoring should be more frequent, which is 4 to 6 weeks. And exacerbations are a risk, not just to the mother, but also to the unborn baby, results in preterm birth, low birth weight babies. And do not do a bronchial provocation test during pregnancy is another mandate from GINA. In elderly patients, there's more chances of heart failure. There's more chances of being asthma COPD overlap. Hence, choose inhalers carefully. The device is important because this is the population where there's more of arthritis, eyesight problems, inspiratory flow rates are low, and hence finding the right device is important in everyone, but especially for elderly population. In COVID-19 and viral upper respiratory tracts, this is something we saw through COVID. In viral upper respiratory tract infections, any infection, including COVID, you would continue the ICS even during respiratory infection. So there was a lot of skepticism at one point about using ICS during an active viral infection. So the viral replication rates were found to be reduced in this population in large population-based studies during COVID. And the same probably holds true even in other viral upper respiratory infections. Occupational asthma is a different section, and it talks about asthma starting in adulthood at workplace, confirm with objective tests, especially a peak flow at work versus away, and stop exposure to the causative agents are things we say about occupational asthma. So I finish off there talking about my key messages. So anti-inflammatory reliever is ICS-containing reliever instead of a SABA by itself. And GINA 2026 talks about two, ICS formoterol in track 1 and an ICS and a SABA in track 2. SABA-only treatment is unsafe and should not be done in most population and all of the adult population. GINA track 1 is anti-inflammatory reliever based, and this is preferred for all adults. Step 1 and 2 is air only, so no maintenance therapy, whereas step 3 and 4 is MART treatment. Anti-inflammatory reliever reduces emergency visits, hospitalizations by as much as 65% versus SABA alone at step 1 and 2. Children 6 to 11, there's no anti-inflammatory reliever, only at steps 1 and 2. Low-dose ICS with every SABA at step 1 is what is advocated, as you heard from Dr. Barnali Bhattacharya. MART only uses only ICS formoterol. You cannot use it with other inhalers. So you cannot use it, for instance, with a salmeterol, with a vilantrol, etc. Step up only after confirming correct inhaler technique, adherence, and I added in comorbidities and correcting them, triggers, etc. Step down after 3 months of good control, but never stop ICS completely. And important, the new biologics which are coming in, and there are biologics which are useful regardless of inflammatory phenotype. So I stop there, and I would be very happy to take any questions either now or later.
Yeah. Thank you, Dr. Rajadhar, for an absolutely brilliant presentation. As always, very clear slides and a lot of very, very important, useful information that the postgraduate students could directly translate into their clinical practice. So thank you so much. In the interest of time, we are very short of time. I can ask you only one question, Dr. Dar. So that question actually has got two components. What is the role of salbutamol nowadays in the treatment of asthma? And second, what about salmeterol fluticasone? Doesn't seem to be there in any of this GINA 2026 report. What does it mean?
Sure. So, Sandeep, please call me Raja. I feel very uncomfortable when you call me Dr. Dar, even at a formal setting. So, I think answer to your second question first. I think salmeterol, vilantrol, etc., do not have the rapid onset of action and hence cannot be used as anti-inflammatory reliever therapy or for MART therapy in asthma. Hence, till now, even though these drugs are efficacious, less side effects, because they do not have the same prompt onset of action, they don't really have a position in the step care management of asthma. I think only in a select group of patients, if for some reason the ICS formoterol combination is not working well, you can go on to a different bronchodilator and try it. In patients who want to use once a day therapy and have very good control, these long-acting drugs like vilantrol along with an ICS can be used. So two different scenarios. One, when you got very good control and a young individual wants to use the inhaler only once a day, you could probably go on to these long-acting or ultra long-acting bronchodilators like vilantrol, etc. And the other scenario, rare though, is when you have a formoterol ICS which doesn't seem to work for some reason, swapping onto a non-MART therapy might be done. Your other question about when to use a SABA in asthma, I would say never in the adult population. So I think that would be a capital never for adults. I think there will be emerging evidence even in the less than 6-year-olds where a SABA is still advocated. But like we have seen in the 6 and 11, there's data which has emerged this time, which has changed guidance. I'm sure even in the less than 6 year of age, there will be emerging evidence about non-SABA therapy, but that's a space still to be filled as far as data is concerned.
Good. Thank you so much, Dr. Rajadhar. It's been a real pleasure to have you here for the Purview program, and we look forward to your participation in other purviews. Thank you so much.
Thank you so much.
Dr. Madhura, all yours now.
Thank you so much, sir. Without we sincere apologies to Dr. Vijay Kumar, sir. He's been waiting for his session, but nevertheless, I'm it's my pleasure to invite you to take the next session. He's going to talk about inhalers, innovation in inhaler devices. How should you choose the right device for the right patient? Dr. Vijay Kumar, over to you.
Thank you. Thank you so much, Dr. Madhura. Let me share my uh, hope audible and then
Yes,
visible,
yes,
right?
yes.
Yeah. And it's absolutely, a great pleasure and honor to participate in Parvi program. Thank you, Salvi Bhai, for having me here. Thank you, sir. And so the biggest, in the interest of time, probably next in 10 minutes, I would love to cover this topic, though my topic is for 20 minutes. Let me see what best that I can do. So, inhaled medication forms the mainstay of management of asthma and COPD. By this time, we all knew very well that to reduce the side effects of medications and then to target the lungs and airways, it is very, very important. Inhalers are the choice and inhaled medications are the choice. And various kinds of devices that we have in the market, if you see, meter dose inhalers, dry powder inhalers, breath actuated inhalers, and nebulizers. So, and 40 years of experience, it says very clearly that, okay, the average of a correct, acceptable, and poor test over the 40 years of observation reveal that it has not changed much. So, still there is a lot of scope for all of us collectively as the torchbearers of our patients in the subcontinent. We have a long way to go to make the inhaler techniques to at least acceptable to level to close to around maximum, and then correct technique to be imparted into our patients to enhance their lung functions and then decrease their exacerbation to maximum possible. So, novel inhaler technologies, can it solve real world challenge and enhance patient care? That's a question. And we'll see now what is there. Okay, if we look at the inhalation of smoking from burning plants like Datura, there is the ancient history reveals close to 4,000 years back, people used to practice such things. And then 1500 years back, it was known that aerosol administration was with Hyoscyamus niger plant vapor to treat patients with respiratory distress. And then the first aerosol inhalation device has came into market in 1778. Then the first pressurized MDA was launched in 1956, and then pressurized DPA, DPA spinhaler was launched in 1971, and then in early 21st century we have the soft mist inhalation devices. What is next? So if you see the breath actuated inhalers in the market. So this breath actuated inhalers works by automatically releasing a dose of medication into the lungs when the user takes a breath in, essentially eliminating need to coordinate or assemble the products for use. Need to coordinate is the biggest disadvantage for pressurized MDA. Assemble the product for use, it's again a problem for when the PMDA is combined along with the spaces, or when dry powder inhalers are used to along with the device. So breath actuated inhalers, actually they work on actuation on inspiration, actuates at a low peak inspiratory flow rates, no hand breath coordination, and compact and very portable. So the errors of PMDA, if you see, so at least 20 studies have revealed with more than 3,600 patients, instance of misuse to the close to the tune of 90%, that is mean around 38%. Common errors which we see are coordination of actuation and inhalation, short breath hold, rapid inspiration, inadequate or no shaking of the inhaler. Dr. Salvi has clearly mentioned in his talk how important is, shaking of PMDI before using immediate usage of inhaler. So abrupt discontinuation of inspiration because of cold Freon effect, and there are challenges in both young and very old, and these are all can be overcome with breath actuated inhalers. What are the how it is going to overcome? So overcomes need of coordination. So BAIs gets actuated at minimal inspiratory flow rates. They are going to increase or improve the asthma control and COPD control. Simple to learn and use, portable and robust, no spacer is required, can be used even in children and elderly. So when we look at the drug deposition studies using gamma scintigraphy camera, so if you see the drug depositions between PMDA and synchrobreath technology, it is very clearly mentioned that significantly greater lung deposition are associated with synchrobreath technology when compared to PMDA when it is checked after 5 minutes of inhalation through the device. So higher in vitro lung deposition was observed with breath actuated inhalers as compared to PMDA, and so this is what solmetrol and fluticasone when it was delivered through breath actuated inhaler versus PMDA, which was a randomized double-blinded 12-week study where our Rajadhar sir was the principal investigator. If you see here, it is very clearly mentions the BAs are very easy to learn, and then they are easy to remember steps of using, and then majority of almost 3/4 of the patients, they preferred breath actuated inhalers when compared to PMDAs. Real world evidence of breath actuated inhaler in Indian asthma and COPD patients, if you see, so there is a clear cut improvement that 77% patients achieved well control of asthma and switching to breath actuated inhalers. Whereas in the same way, significant improvement in Boke's dyspnea score was observed at weeks 4, 8, and 12 from baseline in patients of COPD. So adherence to breath actuated PMDA and MDA and DPA, if you see in obstructive airway disease patient, 50% of patients are poorly adherent to inhalers, and breath actuated MDA users had a better control of obstructive airway disease. Patients adherent to breath actuated inhalers had significantly lower exacerbations and hospitalization risk compared to other inhaler users. So, what is the role in pediatric patients with cases like the published literature says that in ADHD, and then one patient with ASD and ADHD combination, if you see the parents reported that breath actuated inhaler was easier to use in child as well, required less effort for breathing, and was easier to maintain, and the children had a better understanding of using of the device when compared to PMDA, because in children even the coordination becomes a task when using PMDA or PMDA plus spacer. So let's look into what is the overall DPA's role. So DPAs do not require coordination between actuation and inhalation and are easy to use and teach and learn. Fewer patients make errors while using DPAs as compared to PMDAs, and easy to carry on, and no propellant use. So thereby, since propellants are not used, there is no cold freon effect, and also they become the environmental friendly inhalers to use. So do we have a solution for overcoming the difficulties with the conventional unit use of DPIs? That is manual loading of capsules, more training time, increased handling steps, potential misuse, and then moisture susceptibility of capsules. All this can be overcome by using a multi-dose DPIs. So which can potentially reduce handling steps, easier to use and as well teach as well. Reduce the errors in technique, more preferred by the patients, very easy to carry, reduce moisture sensitivity, comes with a dose counter and prevents misuse like sometimes some patients very rarely. So when we don't teach the capsules properly, these patients may swallow the rotacaps can be swallowed, or transcaps can be swallowed. So this kind of thing can be avoided using multi-dose DPIs. So in the interest of time, I'll skip few slides. So multi-dose DPI in vitro evaluation versus unit dose DPI, if you see, almost 30 to 35% drug deposition with sip-heller and consistent dosing across, we see between 30 liter per minute, 60 liter per minute, and then 90 liter per minute as well. The fine particle deposition for formoterol and budesonide were higher with sip-heller at all flow rates as compared to that delivered using unit dose DPIs. The mass miniature aerodynamic property of formoterol and then budesonide delivered through sip-heller and rivalizer were in recommended range of 1 to 5 micron at all flow rates, 30 liter, 60 liter and 90 liter per minute. So again, another important thing, the impact of incorrect inclination angle during inhalation of drug delivery from a new discrete multi-dose dry powder inhaler, an in vitro study which revealed that the emitted doses from formoterol budesonide sip-heller were found to be as recommended label claim standards when activated at recommended inclination angle 0 as well as at angles of 40 degree and 90 degree as well. So, and in vitro evaluation of discrete MDPI versus reservoir MDPI, if you see, the fine particular deposition and then MMAD of formoterol and budesonide were comparable for both MDPAs at the device specific flow rates, indicating similar drug delivery into the lungs under ideal condition using the correct inhaler technique. The MMAD of sip-heller was recommended range of 1 to 5 microns, suggesting optimum lung deposition of the drugs. So 80% of COPD patients have one or more comorbidities like cognitive impairment, muscle weakness, poor hand grip, suboptimal peak inspiratory flow rates, learning disability, may not achieve control even with proper use of inhalers. In such patients, it is always advisable to go ahead and then initiate the nebulized form of drugs. So nowadays we have portable nebulizers like rechargeable with rechargeable batteries, can be charged as just like smartphones. Variety of drugs are now available in nebulized forms, can deliver the treatment even in 5 to 6 minutes. So more efficient nebulizers are available in the market. But remember, variable deposition among jet nebulizers, handheld mesh nebulizers provide greater deposition of drug and reduce variability. Suspension formulations of steroids of drugs should be avoided with mesh nebulizers because this can lead to clogging of the mesh in the mesh nebulizers. So efficacy data generated on mesh nebulizers should not be directly extrapolated to other forms of nebulizers like jet nebulizer. And if you see, the high hygiene medical device include replaceable parts, and nebulizers used repeatedly on vulnerable airways should be no different. We have to ensure the cleaning methods and sterilizing methods of nebulizers should be taught very well to our patient population. So branding multi-disposable nebulizer kits along with the purchase of nebulizer improves patient safety, treatment, compliance, brand trust, and medico-legal protection at minimal cost. So nowadays, we do have in the international market ensifentrine available in the form of nebulized form for effective bronchodilation and anti-inflammatory activity. And with this, I would hand over to Madhuragari ji for further proceedings.
Okay.
Thank you so much,
Thank
sir. Dr. Salvi,
yeah.
if we can have one question for
Yes,
him.
one quick question. I think Dr. Vijay Kumar, what a brilliant talk. Inhaler devices is such an important aspect of asthma management. And as I said in my presentation, dry powder inhaler, fast and deep, and then breath hold, and a pressurized metered dose inhaler, slow and deep, then a breath hold. I think these are so important. In your opinion, Dr. Vijay Kumar, what has been the latest big advancement in inhaler devices that you have started using in your practice for asthma patients, which you believe is very good compared to what was available before?
Sir, I believe it is a breath actuated device are the best devices in the market. So there is no
Okay.
doubt about it. And as mentioned in the talk as well, it becomes very, very easy unless you generate good amount of peaking strength. The device will not get actuated. So the moment it get actuated, it smoothly gets into the lung and then gets deposited. So, and that's what is the beauty of breath actuated inhalers, sir.
Very good, very good. I think now there's also a change in the propellants that are being used. So we earlier had CFC, then we had HFA. HFAs are also believed to be responsible for global warming. So there's
Sir.
going to be a third shift in the use of pressurized metered dose inhalers. There's a there's a bit of a time for India to adopt to that or adapt to that, but at some point of time, these inhalers will also undergo replacement. So I think all in all, inhaler, we are in a very fortunate country to have access to so many different varieties of inhaler devices. And in your opinion, which is a better device, the MDI or the DPI? Or you think it all depends on what the patient prefers?
No, more important, sir, we need to, whatever the device that we are writing, and then we should discuss with the patient and ensure that he or she understand properly and then uses and demonstrate right in front of us properly. So that's what is gives us confidence. And then ultimately, once we train, so the biggest challenge what we face is we assume that on day one, whatever we train, patient will retain it forever.
Yes.
That assumption is a myth. We should ensure the inhaler technique is perfect in every visit unless, patient demonstrate in every visit, probably at least 3-4 times. So I don't remain confident about what is the way the patient is taking the inhalers.
Okay, so two very important messages. Whenever you prescribe an inhaler device, please educate your patient about how to use it correctly. And second, I think very more importantly, please check the inhaler technique use at every visit. And I think that's such an important message that came from you. Very, very important. Thank you very much, Dr. Vijay Kumar Cheramchetty.
Thank you
It's
so
been
much,
a pleasure to have you here at the Purview program. As Dr. Madhura said, there are at least about 2,500 PGs who are listening to this today. And I'm sure they must have benefited a lot with your lovely presentation. Thank you so much.
Thank you so much, sir.
Dr. Madhura, all yours.
Yes, thank you. Thank you, everyone. We will move on to the last part of our purview, which is the quiz. So the faculty may leave if they please to. I will just quickly share the presentation and within the next 10 minutes, we will be done. So let me just share my slides. Right. So with that, we come to the last part, which is the quiz. Let me quickly announce the winners of the previous purview, as well as display the QR code for this time's purview quiz, which you all can participate in. So let me move on. So this is the 68th purview quiz. Right. So let me make the announcements for the previous purview, which was on tuberculosis, which happened in the month of March. So congratulations, Dr. Smrutileka Swain from SCB Medical College, Cuttack, who was the first prize winner. And the second prize winner is also from SCB Medical College, Dr. Shashwat Ray. So congratulations. Our team will be in touch with you for the further details of your prize. Your score was pretty impressive. Right. So now let us move on to this time's quiz. Apologies, that should read 68th and not 67th, but so the instructions always remain the same. I will display a QR code. You can scan the QR code from your mobile and access the quiz. Once you start the quiz, that's when you will have 15 minutes to take all the questions. Please fill all your details properly so that in case you're the winner, we can get in touch with you easily. Multiple choice questions where each question carries 1 point. And as I mentioned, as soon as you scan the QR code, the quiz pops up. That's when your 15 minutes time will start, for which you have 10 questions that you have to answer. Whoever gets the highest number of correct answers and is the fastest to submit the replies shall be the winner. And if you're connected through your phones watching us, then you may have to take a screenshot of the QR code and then open it based on the device that you have, based on the device that you're watching through. Okay, so with that, let me move on. All the best, everyone. The first prize and second prize winners will get 5,000 and 3,000 along with the certificate respectively. All right, ready? So here we go. That's the quiz QR code. All the best. Sure. Is it not in the full screen already? Yeah, sure. Yes, you can. Yes. Yeah, no problem. No problem, no problem. Okay, you can continue taking the quiz. I will close the presentation, and whoever has started can finish it with the time that they have left. Okay, so we can stop the presentation. Goodbye, everyone. We'll see you in the next purview pretty soon. Bye bye.